But one of the things that has become more prevalent in the background is understanding that as we push myeloma to somewhat of a chronic disease, there are other things that need to be taken into consideration, including overall symptom management and a variety of different modalities of how the patient has to live with the disease on a day-to-day basis. And this has become something that we're quite interested in so far as not necessarily just maximizing clinical outcomes in terms of response rates, but maximizing clinical outcomes in terms of the total patient that has to deal with living with cancer. So a pilot study was developed in order to look at a living with cancer patient-reported outcomes tool. And this was validated across a variety of physicians, giving them clinical scenarios of different statuses of patients to determine where along the way they would recommend intervention either by palliative care, hospice care, or cessation of chemotherapy. Once the tool was validated, a second study was looking at over 1,100 patients across a variety of different malignancies to evaluate where along different distress scores patients may benefit from transition to palliative care or hospice care. Subsequently, we actually looked at the subset of that, 239 patients with multiple myeloma, and that's what I'll be presenting on at this year's ASH. The Living with Cancer Patient-Reported Outcomes tool is a survey that involves 4 different domains of personhood. So we look at performance status, burden, pain, and depression. We ask questions along a Likert scale, sometimes, always, never. And then the patients individually weight their responses in terms of how each of those modalities impacts their life, a little, a lot. So they may always feel pain, but it may not be that meaningful to them, or they may feel pain a little time, but that may be very meaningful to them.